Yes. Very good. So exactly that's the case. Except for more than solute at the end, I talk about water because that's the important thing that's just the way the body regulates concentration of the sodium. So I couldn't have said it better. So osmoregulation means that body has some sensors that they sense the amount of osmolality in the body. Okay. And when the osmolality changes, the body tries to compensate for it in a way that the amount of sodium in your body remains unchanged. Make sense? And the other way is volume regulation, which is not as important as osmoregulation, but also body senses the amount of volume in your body. So if you lose blood, for instance, or you get very dehydrated, the body senses that and tries to regulate the amount of water that you're, let's say, urinating. Okay? So it senses that and compensates for that. And I'm going to show you how does those two systems, how do those systems work. So for osmoregulation, we have some sensors in the hypothalamus, and they sense osmotic pressure and they release a hormone called ADH. Do you know what does it stand for, ADH? Very good, excellent. Antidiuretic hormone. What's the other name for ADH or antidiuretic hormone? Very good. Who said? You said, yeah. Arginine vasopressin. Very good. Excellent. All right. So we have hypothalamus that senses what's going on with osmolality, release ADH, and you can get more water gain or loss. It just really calculates what's going on and adjusts the amount of the water you get. And then there is volume regulation. There are other sensors, mainly carotid sinus and atria. And there is a signaling pathway, sympathetic nerves, renin-angiotensin system. It kind of regulate water, but also sodium at the same time. Okay, let's start with ADH, also now known as AVP or ADH. So it goes from hypothalamus. You see, guys, see the arrow or no? Yeah. So there are two sensors here. Both are neurosecretory cells in supraoptic and paraventricular nucleus in hypothalamus. So these are the questions, as you guys know, these are like commonly asked questions in board exam. And before I forget, when I was applying for residency, I went to University of Chicago, and the guy said, "Well, I don't know about medical schools in Spain, but what do you do when a patient comes with hyponatremia?" And I think that's a very good question later on, not because you should know hyponatremia, but mainly because what is your approach? Do you understand the fundamental of medicine and you have a way of thinking through a problem? Even if you are wrong, really doesn't matter. People want to see whether you have a way of approaching a patient with a medical problem. And hyponatremia, it is kind of complicated. So we have those sensors up there in the hypothalamus and they sense what's going on with the osmolality. They secrete ADH, goes to the pituitary gland in the posterior part of it, and then gets released, goes to the kidney, and I show you what happens. But mainly what it does, as the name indicates, really regulates the amount of water in the kidney. And this is something that you guys more or less should know. And this is like after a plasma osmolality of 280, ADH is very responsive to osmolality. As you can see, as you increase osmolality, you can see that the amount of ADH goes up. Osmolality, when it goes up, means that you don't have enough water in the body, right? When you think about it, when you have high osmolality, you need more water in the body, right? So antidiuretic hormone, as the name indicates, it reabsorbs all the water from the urine, from the kidney, so you have more water in the body. So it's very responsive to what's happening with the plasma osmolality. Okay, what does it do? So ABP or ADH binds to this V2 receptor. And this other thing that people ask all the time, V2 receptor or V1 receptor. In the kidneys, in the tubules, you have V2 receptors. It binds to it. It activates an ATPA and PKA system. And at the end, you have these water channels that are called aquaporins. Aquaporin is water, obviously. And aquaporin channels means that they get activated and they reabsorb water from the kidney, from in the tubules. So this is the urine here. This is inside the body, aldosterone. We talked about it yesterday. These aquaporin channels get activated and they reabsorb body inside, that reabsorbs water inside the body. Questions so far? So we went through, well, hyponatremia means that you don't have enough what, sodium, but you have a lot of water. Yeah, okay. So hyponatremia means too much water, and hypernatremia means not enough water. Okay. So your hormones, ADH, is the main regulator of what's happening to the water in the kidneys. If you have hyponatremia, would you have more ADH or less ADH? If your kidneys are working well and they want to respond to hyponatremia, what should happen to ADH? The ADH should decrease. Very good. And if you have hypernatremia, what should happen to you? Okay, very good. Okay. All right. So there are some V1 receptors, and that's those. Let me see where they are. Okay, here. And these are involved with vasoconstriction. These are not the same as V2 receptors. And when you have vasoconstriction, obviously you would have some increase in your blood pressure if the receptors are on vessels. Okay. So what are the stimulus for ABP? How does ABP know that it should get it secreted? The one thing I already showed you guys, right? ABP goes up correlating with what? What does ABP, how does ABP know, oh, well, I should get a start to work because there is a problem? Well, there are two things, right? There are osmoregulation, right? So it responds very well to increase osmolality, right? So osmolality goes up. That's okay. You don't have to. You're thinking too much now. Just as these are very simple concepts, but there is a lot of concept coming together. So ABP, antidiuretic hormone, right? So it reabsorbs water inside the body, correct? So you get more water in the body. So when you have ADH, immediately you have more water in the body, right? Because it activates aquaporin. You reabsorb more water, you get more water. So if you have hyponatremia, what do you think ADH should do? Hyponatremia means what? Too much water. Yeah. So the ADH should go down or should it go high? You should to lower the amount of ADH, right? Because otherwise you even get more water. You don't want that in your body. You want just to decrease the amount of reabsorption of water. Makes sense, or you see just I should go over that one more time? Yeah? Let me ask the not you, but you guys follow that? With hyponatremia, you have too much water, so your ADH should get what? Deactivated, yeah? You don't want that too much of ADH now. With hypernatremia. So with hypernatremia, your osmolality goes up, right? Makes sense? And then you want your ADH to really kick in because you want more water in your body. Okay. Now, in addition to water and osmolality, there's something that just somehow they activate ADH, such as nausea, pain, and some drugs. And these are things that they will ask all the time in your board exams. Okay, the volume receptors, I show some of them here, and these are important. They sense what's going on with the amount of volume that you get in your body. Let's say, you are in an accident and you lose a lot of blood. These sensors, they sense that and they activate a lot of things to maintain your blood pressure. Even though you have less volume, they maintain the blood pressure as well as the amount of sodium in your body and water in the body. And I tell you how that works. So, in contrast to, so these are the two main stimuli for ADH. One is when you have increased osmolality, so you don't have enough water in your body. ADH kicks in. The same thing for thirst. This is the same. Remember, when you're thirsty, you drink because you want more water in your body. And this is the amount of volume. When you lose about 10% of your body volume, so this is not very active because 10% is huge amount of blood loss before they really kick in. But about 5 to 10%, the amount of ADH goes up and then increases. So these two stimuli, the volume and osmolality, are important for the ADH to kick in. Yeah? Okay. Let me just get to, so this is the bottom line. And in order for the ADH to work, okay, it needs this gradient outside the tubules. And you guys know the countercurrent gradient in the kidney. Are you guys familiar with that? The body makes by absorption of sodium in the distal, in the proximal tubule, and later on loop of Henle. It generates a concentration of sodium against which water can get reabsorbed. If you don't have that gradient of sodium in the medullary part of the kidney, water cannot get reabsorbed because you need some osmolality in the kidney for the ADH to kick in. So let's say you have, and this is called, as you can see, the concentrating mechanism. The concentrating mechanism of the kidney is really in the distal tubule in collecting duct, depending on ADH, and concentrating urine happens when your ADH is active and water gets out of the tubules, gets into the body. So obviously urine gets concentrated because you have less water. So ADH gets activated, water gets reabsorbed, and you get concentrated urine. So you can, if you look at your urine, you see that the color becomes very, um, looks like very cloudy because you don't have a lot of water in it. The body tries to get rid of the water before you lose it. So this is the concentrating ability of the kidney by reabsorbing sodium through ADH or diluting. So let's say you have hyponatremia, which by definition means that you have too much water in your body. So what you really want to do is that the ADH doesn't do anything. You lose a lot of water through the urine. That's what you really want to do. So ADH gets downregulated and you lose water. And this is called the diluting mechanism because then you have a very dilute urine. Remember, hyponatremia, too much water, you want to lose water through the urine, right? You have to dilute urine. And those are times that your urine may look almost white because you have so much water in it. Now, these are sometimes complicated concepts, and you're going to go over that during medical school as well as internship, residency, fellowship. And still is, I think, is one of the difficult concepts to really understand. But let's wait here and think about whether we now understand. If a patient comes with hyponatremia, let's focus on that because this is more commonly seen than hypernatremia. So what does that mean for us? And what do we want the body do for us? And what should be the treatment of it? So if somebody has hyponatremia and you're the doctor, what do you want the water? What do you want to do with water if the body is not working well? What do you want to do? Don't think about medication, but in general, what do you want to do with that? I mean, for me, would be get rid of water, right? Because hyponatremia means too much water. You somehow you want to get rid of water in the body. You can't. No, you don't, because don't think about salt in terms of hypo and hypernatremia. Okay, just think about water all the time. Yeah, you can give them like some sort of diuretics, for instance, but don't think about medication. In general, you want to get rid of water. You want to do make sure that ADH is working or not working. Which one? So if you have hyponatremia and they tell you, well, you can sense ADH and make ADH to work. You want the ADH to work or you tell ADH not to work? Not to work. Because if it works, you're going to reabsorb more water. That's not what you want. Yeah, okay. Okay, so hyponatremia would be less than 135. So now we are getting to a practical approach to patient with hyponatremia. So somebody comes to you and sodium is 125, right? You say a patient has hyponatremia, and by definition, it means that they have too much water in the body. Yeah, hypo means too much, is the opposite of what we are talking about. Sodium, hyponatremia means too much water, and hypernatremia means not enough water. Okay. So the first thing we do, we want to make sure that your patient has true hyponatremia because hyponatremia is really a concentration. We want to make sure that this is really hyponatremia. We have to be worried about that. And the way we do it, we check the osmolality in the body. So if you have true hyponatremia, what should it be your osmolality? Low, unchanged, or high? Let me ask somebody else. Um, guys, some of you guys just not you now. What do you think? So you have, I want to tell somebody has hyponatremia, and I ask you when you're rounding with me, is this true hyponatremia? Which means that is it real? Or this is just a problem in terms of measuring concentration? Because with hyponatremia, what should happen to osmolality? Should it be high? Should it be low? Or should it be unchanged? It should be low. By definition, it should be low because you have too much water, right? So if I check the osmolality in my patient, and if it's low, I know that your patient has true hyponatremia, and I move on with what's going on. Now, if I check the osmolality and it's high, that would be unusual, right? I wouldn't be too worried about it because what's happening when you think about osmolality in a cell? That tells me if your osmolality is high, means that there is something in the plasma that moves the water from the cell to the plasma. There is nothing wrong with ADH. It just there is an osmol, an active osmol in plasma that moves water not from the kidney but from all the cells into the plasma. So what happens with that is, let's say you have too much glucose. If somebody is diabetic, for instance, you check the sodium, maybe a slightly lower than normal, not because of what's happening with ADH or volume receptors. It's just question of glucose outside of the cell is an active osmol, which takes the water from inside the cell to outside. So you have too much water outside of the cells. You measure sodium, sodium is unchanged, but now you have too much water, the concentration is low. Yeah, that's the main reason you have high osmolality and hyponatremia. And sometimes that doesn't happen anymore. As I said, when we measure sodium, we are measuring a concentration. And if you have too much lipids or a lot of proteins, the amount of water would be less, artificially less, when you measure the concentration of sodium. Sodium is unchanged, the water is unchanged, but when you measure it, part of the water is filled with lipids or proteins. So artificially, it seems that you have less water at that point. Okay. But that's not the case. So don't worry about so much into when you have normal osmolality, but it's very common to see high osmolality in your board exam because diabetics are common. So you don't want to chase hyponatremia in a patient who is diabetic, but that's not going to do anything for you. The one that we are interested is the ones who have low osmolality because these are true hyponatremia and somehow ADH is not working properly. Makes sense? Because if it was working properly, you shouldn't have had hyponatremia. We don't get hyponatremia, right? Because our ADH is working properly, is responding to what's happening to hypothalamus. So if somebody has hyponatremia, by definition, means that the ADH is working, right? Inappropriately. It shouldn't be working, but it's working. It's maintaining your hyponatremia. All right. The first thing we do, we measure the urine osmolality after serum osmolality. If the urine osmolality is less than 100, that means that the guy is drinking a lot, huge amount of water. Don't worry about them. And those are usually people who are psych patients who drink huge amount of water and it's hard for them to maintain osmolality, not because of ADH is abnormal, just because they drink so much, let's say 6, 7, 8 liters of water, and that makes it very difficult for ADH to compensate. So urine osmolality is very, very low. They have primary polydipsia. That could be also a disease, but most of the time for your board exam, it's somebody who is a psych patient who drinks huge amount of water. Now, if urine osmolality is what more than 100, these are people that we are interested, and we want to see, well, what's going on, and why is the urine osmolality more than 100 is abnormal? Because if you have hyponatremia, what do you expect the urine osmolality be? Should be high or low when you have hyponatremia? Should be high, you think? If they have hyponatremia, you want to get rid of water in the urine, right? You have hyponatremia, you want to get rid of the water in the urine. So what should be your urine osmolality? Huh? What do you think? You already said it. It should be low because you should get more water in the urine if you have hyponatremia, right? But if your urine osmolality is high, means that your ADS is still working, despite the fact that you want to get rid of the water, is not doing that. Yeah. All right. So the next step for us is, so first we check the serum osmolality. Serum osmolality should be low for somebody who has hyponatremia, right? Then we look at urine osmolality. You can look at urine osmolality later on, but it's good in the beginning to look at it because you immediately can think about people who are psych patients, they have primary polydipsia. Now you're getting to the bulk of approaching a patient with hyponatremia. And the first thing you have to do is to look at the volume status of a patient. Volume status of the patient. Because you can have hyponatremia, and even though the concentration of water to sodium is changed, when you look at the patient, they can have a lot of volume on the body, they could be dehydrated, or they seem to be okay. These are three options for us. They can have hypovolemic hyponatremia, they can have euvolemic hyponatremia, or hypervolemic and hyponatremia. And how do we know that? If I go and see my patient, or you come to tell me the patient is hyponatremic, but when I look at them, they look hypovolemic. What does that mean? How do I know, or how do you know the patient is hypovolemic? What do you think? What are the signs or symptoms when you look at somebody? They do look hypo. This is something you just look at them. There is no other measurements. Yeah, they could be sweating. Very good. What else? What makes you think that somebody could be hypovolemic? Yeah, it is not dehydration, because for us, dehydration by definition means somebody who has hypernatremic. But it's the same signs and symptoms. Somebody is dehydrated, so they could be sweating. What else? Very good. So you can look at their skin. What else? What happens to their blood pressure more? Yeah, their blood pressure is kind of lowish. If you ask them, well, open your mouth and let me take a look at your mouth, what would you see? They look dry, wet. Well, if they are kind of dehydrated, then they are dry, yeah, because they are hypovolemic. They don't have enough fluid in their body. They have hyponatremia, but they are hypovolemic. Okay, what does that mean? How is it possible somebody has too much water, but overall it seems that they have lost water? Well, they have lost water overall, but still, as compared to sodium, is high. That's the reason, because it's a concentration. It's not the absolute value. It's just a concentration. So hypovolemia and hypernatremia is the first condition of that. Now, it could be the other way around. You look at somebody and you tell me, Dr. Danesh, this patient has hypervolemia and hyponatremia. And how do you know somebody has hypervolemia? What are the things that you look at it? What do you think? You say, well, this guy has a lot of water. What is it? High blood pressure. Not necessarily, but I see what you're saying. Yeah, it's the other way around. But not everybody who has high blood pressure or hypervolemic, because the body compensate for all of those things. What else? Yeah, just think about just the concept, like somebody has too much water in the body. Well, if you look at them, how do you know somebody is hypervolemic? It's very easy because they have a lot of edema. Yeah, if you see, you just touch on them and they have a lot of fluid in the body. Mhm. Frequent urine, not necessarily, because all of those things get regulated all the time. But the way you know it, you see somebody, this is like the second step, which is whether they are hypervolemic, euvolemic, or hypovolemic. It's just looking at your patient. There are no other tests. It's easy to distinguish that because if somebody is dry, you look at their mouth, they look very dry. Yeah, their blood pressure kind of lowish. They haven't been drinking for a long time. These are dry people. They're hypovolemic. Hypervolemic are somebody who has, let's say, heart disease or liver disease. They have arthritis. They have a lot of fluid in their legs. These are people who are hypervolemic. And euvolemic is somebody has hyponatremia. You look at them, they look normal. They don't have too much fluid on board. They don't look dry either. Yeah. So these are the three options when you look at somebody. You immediately should make that distinction. Hypervolemia, a lot of edema, they have fluid on board. Hypovolemia, they look kind of tired. They look at the mucosa is dry, the blood pressure may be a little bit low. And euvolemic is just normal. They don't have any major issues. So if somebody has hypervolemic hyponatremia, which means that they have edema, there are two conditions for that. Because edema, what causes edema? And this probably you learn later on. If they have heart problems, they get edema. If they have liver problem, they get ascites in the form of edema. Or they have kidney problems, they get edema because they lose protein. So somebody who has hypovolemia, hypervolemia, and hyponatremia, either they have kidney problems, liver problems, or heart problems. And you have to treat the underlying disease for them. Okay? I'm not going to get into checking the urine sodium. We're going to go over that later on. If somebody is hypovolemic, most of the time is because somehow they look dry, but also there are some hormones that are important for them. And sometimes they have been taking diuretics. That could be one reason. And then some of them, they have a hormone that comes from the brain, and that really uh, excretes sodium and water with that. I don't want you get into that so much. The only thing I want you guys to remember is these three conditions: hypervolemia, hypovolemia, and importantly, euvolemia. Somebody who has hyponatremia, but it seems to be okay. And this is the one that they ask you all the time. And this is when, as I said, when you have hyponatremia, your ADH should be deactivated, right? When you have hyponatremia, your ADH should be deactivated. So you lose water. If it's activated, you get SIDH, which is an appropriate secretion of ADH. Is right? Just it should be down, but it still is very active. So what causes that? Well, definitely there are some stimuli that your ADH is responding. It's not volume, it's not Osmolality, so there must be something else that makes this ADH to work all the time. Osmolality is low, ADH should not be activated. Volume should be okay. These are euvolemic patients. So then what's going on? Well, they are some cancers that they excrete ADH. And then you have inappropriate secretion of ADH. There are some lung diseases that secrete ADH. These are not from hypothalamus that comes to the pituitary. These are ADH that comes from other parts of the body. They activate it. You have more inappropriately high ADH when there shouldn't be a lot of ADH. So in cancer patients that I deal with them, it's very common to see hyponatremia, not because of appropriate increase in ADH, it's inappropriate increase because of the tumor cells, they secrete ADH. So the water gets reabsorbed again when you really don't want that. Well, if somebody has, sometimes it's the other way around. Sometimes people have tumor and they get hyponatremia. You know, most likely it's SIDH. So in your board exam, they show somebody with TB, tuberculosis, or cancer who comes with hyponatremia. Most likely these people have SIDH. They are euvolemic, ADH is active, and they want you to know that whether, or they want to ask you whether you know the concept of SIDH. And sometimes the other way around, they have somebody who comes with hyponatremia, they look euvolemic, and then you look for cancer in them. You see, you get an X-ray to see whether they have lung cancer. Is there any cancer anywhere else that they have SIDH? Euvolemic means isovolemic. They don't have too much volume in the body. They are not hypovolemic, which is like not enough water. It's like you are euvolemic. Is that normal? Yes. So you have excess of ADH, but your volume is normal. There are no changes in your volume. That's just by definition that's the way it is. Okay. In other, when you have hypervolemia or hypovolemia, your ADH can get activated. It's inappropriate when you have hyponatremia, but you have a stimulus for it, right? With hypovolemia, your volume is low, your ADH should be high, but it's inappropriate for hyponatremia. Is it too complicated now, guys? No? Okay. Some people they said, no, it's not. Let me ask everybody whether they follow that because it's going to get even a little bit more complicated. You guys follow? I mean, there is no stupid question at this level. Any question you ask is a good question. When you guys go to become a resident and a fellow, then there are some stupid questions. But now, any questions are okay. Okay. Let me go a little bit faster because I don't think you have to worry about it. This is a very important thing for your exams. Some of the cancer, they're not going to ask you specifically what type of cancer, some of the lung diseases, and some of the CNS problem that they could cause an activated ADH or SIDH. So the way I want you guys to study is not just to study for the board. You guys have to study and learn. But part of the way you have to learn is just also to make sure you do well in your board exam. The best way to do it after you learn about hyponatremia, and I cannot teach you hyponatremia, everything about hyponatremia in 1 hour. There are books about hyponatremia, much less in 1 hour for first year medical student. But if you learn the concepts, then you can go and read on your own and look at some of the video clips. internet. There are a lot of information about hyponatremia that you can learn, but you have to have a good concept of what is hyponatremia. Then you learn a lot when you read a book and you look at an internet and Google hyponatremia. There are lots of lectures, good lectures about hyponatremia. Okay. So nausea, vomiting also is a very important concept for SIDH. Okay, now when you think about SIDH, and I emphasize that mostly because these are patients that you see, but also in your board exam, let's think about what do they have. By definition, they have to have a low plasma osmolality, right? We all agree? That's just by definition. They have to have an elevated urine osmolality. Oh, all right, go ahead. But these are you guys have heard this lecture before, right? Some of you guys. Yeah, all right. You guys go ahead. The way I figure out that somebody has SIDH, you look at their BUN and uric acid are very, very low. This is very characteristic of SIDH for practical purposes. Their BUN and uric acid in general are very, very low. So BUN of 2, 3, 4, 5 is not uncommon in this patient, which is not common in other types of hyponatremia. And you have to check adrenal glands and thyroid function. These are like for practical purposes because they look like somebody with hyponatremia. You have to check that before making the diagnosis of SIDH. Okay, so also in a student, medical student, they can get hyponatremia because of drinking too much beer in very short period of time, and they're not eating at the same time. They can get hyponatremic just because of drinking a lot of. And that actually happened not so much in US, but in UK. It used to be a major problem for students, especially medical students. All right. So, what are the signs and symptoms of hyponatremia? If your sodium is very, very low, it's a medical emergency. Okay, this is very important to understand. There are few things that you have to be careful. One of them is when your sodium is very, very low. That is a medical emergency. And these are the few things you ask your intern and resident, go to the patient and make sure they do well. And the way you know that the patient is not doing well is because they come and they're confused. They don't know where they are. They don't know exactly what date is it, what happened to them. They may be in coma even if they severe hyponatremia. Okay, so the goal is to increase the sodium concentration, and depending on what's the reason for hyponatremia. So in hypovolemic hyponatremia, there is too much water. They have lost water, but still they have too much water compared to the sodium amount. Make sense? Overall, they have lost water. They are hypovolemic, but still the amount of water in the body as compared to sodium is high. So you have to give them more fluids to make them better. If they have hypervolemia, they have too much water anyways. So you have to get rid of fluid by giving them diuretics. So they have more water getting out of the urine. And if you have euvolemia, you have to give them, you restrict water for them. You ask them not to drink water. So the amount of water over time goes down and they get better. Now, there are some new treatment. They are called ADH antagonists. And before I talk about that, one thing they ask in your board exam, and that's the reason it's a medical emergency. If you don't treat them well, they get something called PPM, and that's what you see here. Let me actually show that to you guys first. All right. So when you get hyponatremia, if you go look at what happens to the brain gets too much water, right? So the body tries to get rid of some solutes here in the brain. Let me actually put this here for you guys. So, oh, all right. So when you have hyponatremia, the body gets rid of the solutes in the brain slowly, okay, as a way to compensate for hyponatremia. And if you treat this patient too fast, they get something called osmotic demyelination. If you treat them too fast, you bring sodium too fast to the normal values. And this what happens to them. CPM, which is if you look at the pontine here, you see this necrosed area. And this is a medical disaster because the people cannot talk. They look at you, but they are totally paralyzed. And this is something that we do to the patient by treating hyponatremia too fast. All right, I'm going to go a little bit faster since we are a little bit behind. It's the same concept of CPM. And with hypernatremia, none of us we get hypernatremic ever. Only elderly people or people who are unconscious get hypernatremic. And anybody knows why? Because hypernatremia means obviously not enough water, right? We never get hypernatremic. Why is that? Because if you get hypernatremic, what is the immediate response to that? Hmm? No, you can get, I mean, you can get vomiting, but listen, we get hypernatremic all the time, but you really don't see it in the body. And that's because you immediately do something. You go to the fridge and you drink water immediately. Yes. So as soon as your body senses that you're hypernatremic, means that your osmolality is going high, you go, your thirst mechanism kicks in and you go and you drink water. So people who get hypernatremic are people who typically either they don't have access to water or they are in coma or they are elderly people who may not have a good mechanism of sensing and they can get hypernatremic. But in general, hypernatremia, the treatment, you give them water, right? Just one way or the other, you give them water, they get better. Now, in terms of ADH, what should happen to ADH that you see somebody gets hypernatremia? Should you have active ADH or not enough ADH to get hypernatremia? Very good. Exactly right. And that's just the way, I don't want you guys to memorize that, but exactly the same thing that she said. With hypernatremia means that you don't have enough water. So ADH that is supposed to be working, reabsorb water for you, is not doing its job, right? Otherwise, the water gets reabsorbed in the body. So if ADH is not working properly, there is a problem with ADH. And the two main problems with ADH are either they don't get secreted or the kidneys, they get resistant to ADH. These are the two main problems. Either ADH does not get secreted, okay? That's called diabetes insipidus. Diabetes insipidus. Why do they call it diabetes? Anybody know? That your ADH is not working properly. They get diabetes. Because what do you expect ADH do? To reabsorb water. If it's not working, what's going to happen to your urine? You're going to urinate a lot. Even though you are hypernatremic, you're urinating a lot. This is a pathological condition. It should be the other way around. You shouldn't be urinating much. So if you are urinating a lot, that's called diabetes, right? Diabetes mellitus when you're urinating a lot because of high glucose. Diabetes insipidus when you are urinating a lot when you have hypernatremia. All right, let me just say two different types of. Okay, so as I said, there are just two types of a problem with ADH or diabetes insipidus, central or renal or nephrogenic. Central means that ADH is not appropriately getting stimulated in hypothalamus, and nephrogenic means that it's not responding to ADH. And how do we know which one is which? Well, central diabetes insipidus are diseases in the head usually. Either you have a pituitary surgery, their problem, head trauma, things that happen to your head and your ADH is not functioning anymore. And nephrogenic diabetes insipidus is that when you get resistant to the effect of ADH, you can look at that. But the way we figure out which one is which, we do this test. And this is the test they may ask you in your board exam. Now, if ADH is not working, means that it's not responding to osmoreceptors, right? So what you do, you restrict water for them. If you restrict water, you expect that ADH goes up. You measure ADH. Make sense? You restrict water, you measure ADH in these people. So this is the normal response. The first one goes up. ADH goes up as you water restrict them. And then at the end, you give them ABP, just inject ABP to them, which is the same as ADH. When you add ADH, you don't see additional change because they have enough ADH. The external ADH is not going to do anything for them. Now, if you have central DI, which is this one, a complete central DI, obviously ADH is not going to be responding to water restriction. It doesn't respond to osmolality, right? Because it doesn't get secreted. ADH is not getting secreted from hypothalamus. If you give them ADH, though, the amount of ADH is going to go up. This is endogenous ADH, right? You give them ADH, the amount goes. If you have nephrogenic DI, okay, you see that no matter what happens, even if you give them ADH, nothing happens to them because ADH, they are resistant to the effect of ADH. Even if you give them ADH, nothing happens to the amount of ADH because it's not going to be responding to it. Make sense? They are resistant to the effect of ADH, called nephrogenic DI. The partial, I mean, I'm not going to explain it today, but we can explain later on. Okay, and in general, you give them water. For central diabetes insipidus, you can give them ABP intranasally. Just in, they just it's like people of asthma. You can give them ADH. It's called desmopressin or ADH, and that works that way. And for nephrogenic DI, you give them thiazide, mainly because you're making them volume depleted. You give them diuretic. You make them a little bit volume depleted because otherwise they're going to be urinating all the time. So diabetes insipidus, there are people who are urinating a lot, despite the fact they are hypernatremic. They shouldn't be urinating a lot. Right? Okay, I'm gonna stop here and say a lot of information for you guys. I'm hoping with GFR we get a little bit easier so we don't go that much of it. This is a complicated topic, really. And you guys have maybe to sit down and think about the concept of hypervolemia and hypervolemia to get it. Questions? No? You have a question? You're the least person that I expected to have question. Nephrogenic, yeah. Well, you give them, as I said, you can start some medication. The reason sometimes is that there are underlying diseases for nephrogenic DI. So, for instance, some drugs can do that for you. And some people who have high calcium, then the tubules, they don't respond to ADH at that time. Even if you give them ADH, it doesn't work. So there are some diuretics you give them just to make them mildly volume depleted, and just the way it works for them. We don't have a specific treatment for it. We treat the underlying disease. All right, guys.